Welcome to the deep dive. Today we're getting into something really fundamental, how high-quality trauma and orthopedic care is actually delivered or should be delivered within the NHS.
And we're using a fascinating source for this, aren't we? The British Orthopaedic Association's advisory book for consultants. It's not exactly bedside reading, but it's critical stuff.
Exactly. It's aimed squarely at senior doctors, consultants who are navigating, well, what the book itself calls unprecedented change.
That's right. More demand, resources stretched thin, constant pressure on targets. That 18-week wait time, for instance. It's a tough environment.
So our mission today, using this BOA book, is to really unpack what it takes. What are the standards, the challenges, the absolute must-haves for leading an orthopedic service safely and effectively?
Well, it kicks off by highlighting quite a big shift in what's expected of a consultant.
Oh, how so?
He talks about moving away from just being consultant-led, sort of overseeing things, towards being consultant-delivered.
Meaning much more hands-on involvement right through the patient's journey.
Precisely. Direct involvement. And it's not just about the surgery itself. It's leadership. It's engaging with commissioning, shaping how care pathways work,
Yeah.
the whole system.
And showing that the care is high quality. How does the book advise on that?
Well, outcomes measurement is central. And orthopedics actually has a bit of history here. The book mentions E.A. Codman way back, pushing this idea of the end result concept, basically tracking what actually happens to patients.
That's quite forward-thinking for the early 20th century. And today that means things like PROMs, patient-reported outcome measures.
Exactly. PROMS, patient-reported experience, measures PREMS, the friends and family test. So it's not just did the operation fix the problem, but what was the patient's actual experience like?
Which feels much more holistic.
It is. And it's not just optional data collection. For GMC revalidation, the process all doctors go through every 5 years to prove they're fit to practice. There's a clear expectation to measure your own patient's experience. It's about accountability, really.
Mm-hmm. And speaking of patients, the book tackles something quite specific, doesn't it? About patients wanting to see the same surgeon.
Yes, this is a really key point for the BOA. They're quite wary of pooled waiting lists if they aren't managed very carefully.
Because of the risk of feeling like just a number?
Partly, yes, depersonalization, not knowing who's actually going to do your operation, but also lack of clarity on who's responsible. The BOA insists on proper patient consent for that model, and that should only happen after a full pre-assessment, ideally where the patient meets the operating surgeon.
You shouldn't be meeting them for the first time just before you go under.
Definitely not. It undermines that trust, doesn't it?
Absolutely. Okay, let's shift focus slightly to the consultant's professional life. Revalidation is obviously huge.
It is. Fundamentally, it's there to assure everyone, patients, the public, employers, that doctors are up to date, competent, and safe. It's a 5-year cycle linked to a responsible officer in their organization who then recommends to the GMC.
And staying up to date involves continuing professional development, CPD.
Essential. And it's a statutory requirement for revalidation. It can't just be narrow clinical stuff either. It needs to cover everything: clinical practice, academic work, management, leadership. The book suggests about 50 hours, or points, a year.
And reflective practice is important there too.
Very much so. Not just attending a course, but reflecting on what you learned and how it changes your practice. And study leave, maybe 10 days a year with pay and expenses, is needed to make this happen.
But how does that fit into a packed consultant schedule? That's where SBA time comes in.
Exactly. Supporting professional activity time. The BOA book is really clear. This isn't downtime or an optional extra. It's essential for professional development, for quality improvement, for patient safety. It has to be part of the job plan.
So it's protected time for things other than direct patient contact.
That's it. And the book splits it a bit. There's core SPA things like your CPD, keeping up with journals, appraisal prep, mandatory training, and then employer-directed SPA that could be audit, research, governance meetings, management roles, teaching.
And external duties too, like working with the Royal Colleges.
Yes, that counts too. And the evidence, particularly thinking back to reports like the Francis Inquiry, just underlines how vital protected SBA time is for maintaining quality and safety. You can't do it on the fly.
Okay, that makes sense. So moving from the individual consultant to the service itself, what are the building blocks? What does the book say is required for a good T&O service?
Right. The nuts and bolts. It talks about beds and facilities, no magic number, but guiding principles. Things like efficient pre-assessment clinics are highlighted. They're key for sorting patient fitness, reducing cancellations, getting discharge planning started early.
And things like day surgery.
Yes, ambulatory care. It can work well, help manage bed pressures, but only with really careful patient selection and good post-op support, like follow-up calls.
And infection control must be huge in orthopedics.
Absolutely massive. You cannot overstate it. Think MRSA screening and treatment, how you manage patients who do have infections, the devastating cost, human and financial, of infected joint replacements. It's critical.
And that relies on staff as well as processes.
Totally. You need enough properly trained staff, orthopedic nurses who know the procedures, physios, OTs. And the book flags the need for 7-day working to maintain standards across the week, not just Monday to Friday.
It also mentions the debate about where services are located, combining trauma and elective, or keeping them separate.
Yeah, pros and cons. Combined sites can seem efficient, but elective lists often get canceled for trauma emergencies. That's hugely disruptive.
I can imagine.
Separate sites protect the planned work, but then you have potential issues with staff traveling, duplicating kit, maybe losing that cross cover. There's no single perfect model. It depends on local circumstances.
And the book is emphatic about needing the right staff, beyond just doctors.
Oh, absolutely. High-quality nursing is vital, ideally nurses with specific orthopedic qualifications or experience. Staffing numbers need to reflect the workload and patient dependency with the right skill mix.
What about advanced practitioners, nurse practitioners, physio practitioners?
They have an important role, definitely. Extended scope practitioners, advanced nurse practitioners. But the book is clear. The consultant keeps overall clinical responsibility, and patients must know who they're seeing and what their qualifications are. Transparency is key.
And physio and OT, obviously crucial for recovery.
Fundamental for getting people moving, getting them home safely, helping them regain independence. For inpatients, the book recommends a specialist orthophysio lead. Staffing needs to match the case complexity. Major trauma or big revision surgeries need more input.
And 7-day physio helps with that, getting people home sooner.
It does, helps reduce length of stay. And occupational therapists are vital to assessing home environments, organizing equipment, splints, helping with a return to work. They're key for timely discharge. Consultant support is often needed to make sure these therapy services get the resources they need.
Hand therapy even gets its own section.
It does, because it's so specialized and makes such a difference to outcomes after hand injuries or surgery. Needs dedicated therapists, physios, or OTs, ideally working towards accreditation. The book even suggests a staffing ratio, roughly 1 senior therapist plus support per hand consultant.
Okay, let's step inside the operating theater. What are the essentials there, according to the BOA?
Dedicated theater time is non-negotiable. Not enough allocated time just leads to cancellations. Simple as that.
Which impacts waiting lists and patient stress.
Hugely. So you need regular scheduled trauma lists every day, plus 24/7 emergency cover with senior surgeons and anesthetists available. Clean elective cases need to be separated from trauma or potentially infected cases.
And timing is critical for emergencies.
Yes. Immediate access for some things, dislocated hips, compartment syndrome, and for most long bone fractures, access within 24 hours is the standard. Open fractures need timely debridement too, although the old strict 6-hour rule is less rigid now unless it's heavily contaminated. Access to good imaging in theater is also vital.
What about the air in the theater? I know that's a big focus for joint replacements.
It is. Ultra-clean air ventilation systems, UCA, are mandatory for joint replacements and major implant surgery. It's a key part of preventing infection.
Does it make a difference?
The evidence suggests it does, significantly. The book cites data showing that UCA, combined with prophylactic antibiotics, slash deep infection rates historically, from maybe 11% right down to newer 0.3%. Patient factors like diabetes or smoking matter too. Of course, they need optimizing, but the environment is critical.
And the BOA has strong views on general theater practice.
Very strong. Orthopedic implant surgery demands, they argue, higher sterile precautions than many other types of surgery. Strict control of who's in theater, how they move, impermeable gowns, drapes, hoods, masks, the whole setup.
And they back surgeons who refuse to operate if standards aren't met.
Yes, the book explicitly states they support members who feel patient safety is compromised by substandard conditions. That's quite a statement.
Instrument cleaning, decontamination, another vital step.
Absolutely vital. Whether it's done on-site or centrally, the process has to be robust. A crucial point the book makes. If you don't have an immediate way to re-sterilize a dropped instrument on-site, you really need 2 sets available before you start. And teamwork between the theater team and decontamination staff is essential.
What about small things like screws? Should they be in individual packets?
Interestingly, the BOA view is, no, Probably not. They argue it's actually more expensive, takes longer during the operation, and might even increase infection risk because of all the extra handling, movement, opening packets.
So better to have them sterilized on a rack with the main instruments?
That's their preference, yes.
Yeah.
Seems counterintuitive, perhaps, but their reasoning is about minimizing operating time and movement.
What else? Blood banks? Tissue banks?
Need access to both, and they must be properly accredited by the MHRA. Hospitals need clear protocols for blood use, transfusion triggers, maybe using cell salvage techniques to conserve blood.
And risks to staff.
Yeah.
Bloodborne viruses.
Yes. Orthopedics is higher risk because of power tools, sharp bone fragments, irrigation fluid. Hep B immunization is recommended. Assume every patient is potentially infectious. Use proper PPE like splash guard masks. And have clear procedures if someone does get an exposure.
Okay. Outside of theaters clinics, outpatient and fracture clinics need specific things too.
They do. Ideally purpose-designed, near X-ray in the plaster room. Enough rooms, big enough for teaching, proper walls for privacy, not just curtains. Separate areas for clean dressings and potentially contaminated ones. Enough staff for smooth flow, chaperones available. Fracture clinics should also check for falls risk, bone health.
And getting information right notes, letters.
Crucial. Medical records need to be easily available. Letters to GPs should be out within 3 working days, accurate, saying what the plan is, risks, benefits. Same for discharge summaries. Operation notes need to be detailed, legible or typed, listing everyone involved, the implants used, any issues, clear post-op instructions.
Sounds like a lot of admin. Where does the consultant do all this?
Good point. The book stresses that proper office accommodation isn't a luxury. Each consultant needs their own office, ideally equipped with IT access. It's needed for that admin time, for SPA activities, leadership tasks, hot desking, strongly discouraged, inefficient, insecure. Juniors need decent space too.
And medical secretaries are key to managing that admin load.
Absolutely essential. The book is very firm. At least one full-time trained medical secretary per consultant is needed for a safe, effective service. They're the link with GPs, patients, coordinating everything. A named secretary helps the consultant work efficiently and safely. And you need cover for when they're on leave.
Teaching facilities also get a mention.
Yes, a dedicated room for teaching, for multidisciplinary meetings, trauma handovers. Access to simulation facilities is increasingly important for training safely, and good IT for accessing online journals and resources.
Let's just quickly revisit SPA time supporting professional activity. You said it was crucial.
Yes, the book really hammers this home. It's fundamental for keeping skills up, improving the service, patient safety, innovation. It cites the Francis Report. It lists those core things like CPD and appraisal, and the employer-directed stuff like audit, research management, plus time for external roles. It's not optional.
Okay. Now, what about patients with particularly complex needs? How should services cater for them?
This requires access to a whole range of support services, and the book notes that provision varies across the country. Things like rehab physio, OT, hand therapy, but also special support like care of the elderly teams, especially for hip fractures, social services input for discharge. 7-day trauma management is vital here too. And often, it means linking with regional specialized services and other hospitals. Clear pathways, named contacts are needed. Things like image exchange portals, IDPs are essential for sharing scans for discussion.
What sort of specialized services?
Major trauma networks, obviously. Specialist spinal injury services. Plastic surgery for complex limb reconstruction. Vascular surgery for injuries involving blood vessels. Neurosurgery. The list goes on. Smooth pathways and communication between centers are key.
And specialist orthopedic hospitals, they have a particular role?
They do. Centers of excellence, hubs for networks, dealing with the most complex cases, leading on training and research. They face funding challenges as the national tariff doesn't always reflect that complexity, but they're vital. They need top-notch facilities themselves, of course.
The book also talks about treatment centers, ISTCs or NHS-TCs. What was a take on those?
Well, it outlines their development set up to boost capacity, sometimes using non-UK staff initially. They often focused on straightforward elective cases, which could concentrate the complex work back in NHS hospitals.
Were there concerns?
Yes. The BOA flagged concerns about quality assurance, short contracts, lack of mandatory audit into complications. And a big one was the risk of separating elective and trauma work, potentially de-skilling surgeons in acute hospitals and harming training. The hope or expectation was they'd become better integrated, staffed by UK-trained surgeons.
And the major trauma networks themselves, set up from 2012 in England?
A big shift. Getting patients to the right place fast. Major trauma centers or trauma units. Orthopedic surgeons are key members of the MTC teams, needing to be readily available. Surgeons in the TUs manage a range of trauma, but need to be expert in that initial stabilization phase. Good communication for repatriation is crucial.
Underpinning all of this, though, is the workforce itself. The book seems quite concerned here.
Definitely. It's a major theme. Trying to pin down exact numbers needed is hard because care is spread across NHS, private sector, treatment centers. But the trend is undeniable. Demand is soaring. Aging population, more active population, rising joint replacements.
And trauma isn't going away.
No, hip fractures particularly. The book estimates a capacity gap, maybe 15% shortfall currently. And the workforce is changing, more women, people working longer. But the absolute key message is consultants cannot work effectively or safely without enough support staff. Junior doctors, nurses, therapists, admin staff. There's often a mismatch between the need and the actual posts available.
Right. Let's touch on how the book advises assessing consultant workload. Section 2, I think.
Yes. It starts by stating the obvious, perhaps, but it's crucial. Workload capacity depends hugely on facilities and support. Deficiencies hold consultants back. It also acknowledges consultants often work well beyond their contracts.
The 2003 contract introduced programmed activities, PAs.
That's right, in England, Scotland, and Northern Ireland. Replacing the old notional half-days. A PA is roughly 4 hours, standard week is 10 PAs. Wales had a slightly different system. The idea, through job planning, was to make the whole workload transparent and ensure extra work was recognized. So the job plan is key. It's an agreement, reviewed annually, detailing all the duties. Direct clinical care, DCC, supporting professional activities, SPA, any extra roles like clinical director, on-call work, emergency visits, travel times, it's all part of it and should be factored in. The 2003-04 contract specifically allocated PAs for being on call.
What about how often consultants should be on call?
Ideally, the book suggests no more frequent than a 1 in 6 rota, though small units might struggle with that. The intensity, how busy it actually is, whether there's good junior support, needs to be reflected in the PA allocation. The aim is to plan activity rather than rely on excessive unplanned extra hours. Up to 12 PAs total can be paid. Beyond that might be time off in lieu. Resident on-call isn't standard unless specifically agreed.
And specific tasks. How do they fit in the workload? Fracture clinics.
Can be unpredictable with new patients, but need proper staffing under consultant direction. Trained orthopedic practitioners can see some patients. Ward rounds are essential clinical time, part of DCC.
Operating lists.
Need to maximize theater use. Trend towards more complex cases on inpatient lists. Need enough time between cases. Orthopedics often needs longer turnover. And crucially, time for supervising trainees must be built in. It's a balancing act between theater and clinic time to manage waiting lists. Audit is non-negotiable too. Part of governance. Regular sessions needed. Contributing data to national registries like the NJR is standard, but needs admin support. Consultant involvement in management, clinical directorates is also important. Orthopedics is expensive, needs clinical input on spending.
And emergency surgery. We touched on theater access.
Yes, resources need to be there when needed. Dedicated emergency theater. And training means supervision. Complex emergencies need direct consultant supervision, or at least the consultant needs to be informed, even for minor cases done by trainees. Rotas should allow the on-call consultant to be free to supervise.
Finally, what about part-time consultants?
Generally, duties are pro rata. But the book rightly points out that things like committee work or departmental roles might need specific allocation, irrespective of their part-time hours, to ensure their contribution isn't lost. The standard DCC to SPA ratio under the 2003 contract is roughly 2.1. So, reading through this book, it paints an incredibly detailed picture of just how vast the consultant orthopedic surgeon's role is now. It's far beyond just operating.
It really is. Clinical expertise, yes, but also leadership, team coordination, upholding really strict safety standards, theater protocols, infection control, record keeping, plus that constant need for professional development, revalidation, CPD, that vital SPA time.
And doing all that while navigating the complexities of the NHS structure, the workforce shortages we talked about, the different ways services are provided, it's a huge undertaking.
The book really does feel like that essential guide, trying to help consultants, as it says, get things right against a backdrop of huge demand and constant change. It highlights how much relies on having the right infrastructure, the right staffing, and that protected time.
Absolutely. And understanding these pressures, these standards, these requirements outlined here, it's valuable insight for anyone involved in healthcare in the NHS, whatever their role.
If you found this deep dive helpful, we'd really appreciate it if you could take a moment to rate and share the show. So here's a final thought. Given the increasing demand we know is coming, the aging population, people staying active longer, and that acknowledged capacity gap in orthopedics, how can innovation in service delivery genuinely ensure that quality and safety are protected for every patient needing musculoskeletal care in the future?